It's great to be back to another normal birth research conference, particularly virtually and particularly as hosted by India. We would have loved to have all met together, which was the original plan, face-to-face, but clearly circumstances haven't allowed that. So being here with you now is a great alternative. So I want to just reflect back on where we've come from. This conference started a long time ago, 2001, in fact, and many years since then it's been held at Grange-over-Sands, which is where this picture's taken in the UK, every other year, usually at this hotel in the UK, and in between, as now, in the years in between overseas, so in this case, India, with everybody here. So the reason that the conference was set up because there was a clear lack of research on the physiology of the maternity episode or of practices associated with it, because interventions are rising all around the world, and I know that's true in India as much as everywhere else, although there's the phenomenon of too little, too late, too much, too soon in India and many other countries. Concerns about unintended consequences and lost skills, that we didn't know what we didn't know anymore. And also a desire to what we call change the conversation. So to have different kinds of conversations about what this phenomenon of normal birth or physiological birth really is, with across all disciplines and all relevant disciplines and with childbearing women. So since 2001, there have been some major changes in the global conversation. As many of you will know, the World Health Organization has produced these guidelines on antenatal care, and then the ones on intrapartum care that are framed around this notion of a positive childbirth experience. So for the first time, they're framed partly around what women say matters to them, not just about their experiences of care, but what actually matters to them about being pregnant and about having a baby. And so this notion of a positive experience is becoming quite embedded in the consciousness, really, of the global community. The thing that came out of that research, that came out of that qualitative research around what mattered to women all around the world in all languages from all countries, was this notion of both safety and well-being, that it wasn't either one or the other, it was both that mattered to women. So in the study we published about intrapartum care, childbirth, as you can see, a number of studies, a number of countries, we're pretty confident in the data. And what we found mattered to women was this notion of positive experience, but something that fulfills their primary beliefs and expectations, which is obviously giving birth to a healthy baby as far as is possible in a clinically and psychologically safe environment, so a place where there was good, respectful care. And again, respectful care and practical and emotional support from kind staff. Most women in most countries around the world, in most languages that we found papers in, wanted a physiological labour and birth. But most also acknowledged that sometimes they had to just go with the flow, that, if things weren't going to work out, sometimes they didn't, they would just go with the flow. But the most important thing about that was that if they did need intervention, or if they wanted it, then they wanted to retain a sense of achievement and control. That was really important to them. It's also, this paper is actually really quite interesting. So this is a paper that is quite recent, as you can see, 2019, Lancet Global Health. And what they looked at is whether actually giving birth in a facility did reduce maternal mortality. So they were looking at two large cluster RCTs, so there were 64 facilities in Ghana. And they actually found that if you had a higher proportion of births in facilities, you didn't necessarily get an equivalently higher proportion of reductions in mortality outcomes. What mattered was where facilities could both support EMOC, emergency care, and safeguarding uncomplicated births. So that capacity to do this thing that we've talked about forever in maternity care and also in obstetrics, actually, the art and the science, those things together, which has been reinforced recently by the Lancet series on midwifery, this notion that it isn't one or the other, not safety or well-being, not being able to do cesareans or being able to make sure that women can have positive normal births if they're able and want to. It's both of them together that really matter. Both and I'm going to come back to that later. So the question really within the COVID situation, I'll just move this down a little bit so you can see, is that we do seem to be back in this space of safety or well-being. And I think this is an interesting paper. It's actually about people living in German nursing homes and their mental health. So nothing to do with maternity, but it makes the point that actually We have to balance these things, infection management and person-centered care, both and, not either or. And it comes back to the fundamental questions that we were asking at the beginning of the Normal Birth Conference. How can we balance the capacity for women to give birth the way they want to, while also ensuring them and their babies are safe? And there are a whole range of notions of what safety is, of course, as well. Psychological, emotional, physical, spiritual safety, cultural safety, or social safety are all important, but we tend to hypervalue clinical safety and short-term clinical safety. And this piece here is saying that, you know, even in a pandemic like COVID, we must not do that. And we know that a lot of the debate has been about the risks of not understanding the value of relationships and people while we protect people from infection. So this very recent study came out August this year, and it was basically looking at the consequences of the pandemic. So the next few slides, or the next chunk of slides I'm going to talk about, are going to be kind of nuanced, really, both aspects. Again, not necessarily saying a thing is good or a thing is bad, but how these two components kind of fit together, I suppose. So this is a review of a number of countries, not all countries in the world, but a number of countries and their reported planning, the reported capacity and planning in relation to COVID-19 across a whole range of services. This particular slide, as you can see, is around reproductive health. And generally speaking, so the yellow is partial disruption and the pink is severe disruption. So you can see about 66% disruption to facility-based births, not necessarily much severe, but still disruption, much more disruption to antenatal care. And then there are a range of other areas here that have been disrupted. But from our point of view, I suppose these are the two that are possibly most important. And of course, you know, if you do have, this is more than the, 56% total, sorry, there, and 34% total there. So 1 in 3 and over half having disruption of some kind or another around the world, which obviously makes a difference to the outcomes for mothers and babies. There's been a whole debate about neonatal unit visiting, and this is reporting like many other papers have done, but this is a multi-country report which basically says, yes, there's been a lot of disruption to the capacity for parents to actually visit neonatal units, so down from 83% to 53%. But I thought what was interesting here is what works. So you might not be able to see very clearly with this yellow, but basically what they said is that single room design can attenuate the effect. Now, of course, that's very difficult to have, especially in a low-income country, a single unit. But this is saying that, you know, there are ways of actually trying to mitigate the effects. It's not necessarily across the board that there are problems. This is impact on companionship, which is a big debate in the UK at the moment and actually many other countries. So companionship specifically to antenatal visits and very specifically to ultrasound scans, where there seems to be a real issue about allowing women to have somebody with them for their scan, and even there are restrictions on using video monitoring or phone conversations, so that, you know, you can have women who are being scanned and being told they've had a late miscarriage or the baby's got abnormalities and they've got nobody with them, and that is seen as being in the press as being a very problematic thing. And the same for labour. There are some hospitals that have restricted visiting, or not visiting, companionship during labour. That seems to be improving, it has to be said. But in the first round, there was a lot of debate about that, and I know that's been the case around the world as well. Impact on breastfeeding. So again, this is a relatively recent paper, and this is UK. And basically what they found, again, mixed messages. So actually almost half of mothers felt that breastfeeding was protected during lockdown because they were not at work, first of all. And secondly, they didn't have lots of visitors. So they were able to just settle down to breastfeeding. So some of them did find that actually very helpful in terms of establishing breastfeeding as a positive effect. But about 1 in 3 had real problems and found that the lockdown, specifically the times of lockdown, were very problematic because they couldn't have help and support. And possibly unsurprisingly, this was more likely for women who had lower education, were living in more challenging living circumstances, and for Black and minority ethnic background. And this is a constant theme, specifically Black and minority ethnic background, around what's been happening during COVID-19 and where there needs to be some real thinking about how we take maternity services forward in the future positively. There's certainly been an increase, or there appears to have been an increase in so-called free birth, or home birth and free birthing in the UK and the US. I think there are accounts of this in Australia as well. I don't know about other countries, but women who don't want to go to the hospital because they're afraid of the infection risk, and so they either book for a home birth, or if they can't have a home birth, they birth by themselves, which is obviously not, well, a booked home birth with good support, the evidence seems to show in countries that have good support for transfers is not particularly risky unless you're a first-time mum, in which case the baby has a slightly increased risk. But certainly if you're not a first-time mum and you're healthy, there's good infrastructure, home birth doesn't seem to be a huge problem. But if women are free birthing, that is birthing with no help at all, with no professional input, that becomes a different issue. And there are risks obviously associated with that. And we don't yet know what the consequences have been so far of that change. Maternal mental health, again, this particular paper said that more than half of participants report feeling down, lonely, irritable, and worried. But again, is the kind of balancing side of this is that greater support for maternal mental health and with household chores, for maternal health and with household chores, shows positive associations. So there were, again, ways in which it looked like women are supported now again, probably women who've got better accommodation, who can get out into the garden, or who have a partner at home, very likely. So there's going to be inequity here. But the point is that it isn't inevitable that women are lonely, and there could well be ways of solving that problem. The other question is, are healthy pregnant women really actually at risk? Now, again, I'm not sure how it was in many other countries, but in the UK, there was a very early assumption that pregnant women were at risk, were specifically at risk. And to an extent, that's kind of understandable because pregnant women are immunosuppressed in pregnancy, and because there have been higher risks to women for other viral infections, other viral epidemics that have been noted around the world. So it wasn't that was a fairly logical assumption in the first stages, but it does now seem that there actually is no evidence that pregnant women who get coronavirus are more at risk of serious complications than the general population. And in fact, young, healthy women are less likely to get coronavirus than almost any other group, apart from children. So at least in the UK setting, and I think that's possibly true in many other settings too. So it doesn't seem at the moment that women who are pregnant are specifically at risk. When we look at the data on clinical characteristics and transmission, so this is a recent systematic review that was undertaken in the Australian-New Zealand Journal of O&G. So they included 60 studies with about 1,300 confirmed cases in pregnancy. And as I said before, the critical illness was about the same as that for non-pregnant women. 19 neonates were positive, but although these authors conclude that the vertical transmission is possible, there's no strong evidence that it's actually happening. And this has been true. This is another systematic review, which is what they call a living systematic review, meaning that it gets updated regularly. It's not just put on the shelf. So this particular version of it, so about 10% of women attending hospital had suspected or confirmed COVID-19. About 0.1% died from any cause. Whether they had COVID, but they could have died from a range of causes. And we know there are certain pre-existing comorbidities that make that particularly likely, as you can see here, the usual things. So, if you had comorbidity, then you were more likely to have all of these phenomena. But I looked at the USA CDC data, and about 51 per 3.2 million pregnant women died from COVID, according to CDC data, versus, as you can see here, so 1 in 63,000 versus 1 in 1,300 of the general population. So it happens, but it's very unusual. And again, COVID transmissions, this is postnatally now, doesn't seem to be transmitted via breast milk from this study, but the Lancet study says it's very unlikely and the vertical transmission is rare. Again, back to this study, the benefits outweigh the risks. Infection measures should be in place. Breastfeeding should be encouraged. So again, this is good news. Breastfeeding should be encouraged. Mothers and babies should be kept together. This study says if mothers are too ill to breastfeed, they should still be supported to express their milk and the baby fed breast milk. The big thing that has come out, as I mentioned before, is this issue of inequality. So in the UK, at the point when this particular report came out, 8 women had died, 8 pregnant women, that is, 8 pregnant labour postnatal women had died from COVID-19. 7 of whom had an ethnic minority background. That is wildly out of proportion to the rate of women from an ethnic minority background in the UK. So there is a serious problem with how women from an ethnic minority background are responded to when they're pregnant and when they're not pregnant as well, and that's a really big issue. The other issue is the staff risk. So the kind of other area that seems to be restricting women from mobilizing or breastfeeding or having spontaneous births or whatever, or having somebody accompany them during antenatal care, is this risk of infecting staff. And this is an interesting paper. You can't read the detail, I know, but basically what is said is that those who work in intensive care, staff who worked in intensive care situations, actually were really unlikely to get COVID-19. It was more likely to be those who were frontline facing, but not in intensive care, which is a bit paradoxical. But what they conclude is it's probably to do with PPE, that staff who are working in intensive care, particularly after the first wave, are much more likely to get very high quality PPE equipment than those who are in frontline facing, but not intensive care situations, which raises an issue about how staff can be protected to provide the best possible care. You know, you'll all know that around the world, lots of staff have come up with amazingly inventive ways to be more personable, more humane with all the gear on, writing their names on the top, or having masks with smiles on, or being very careful to smile with their eyes. Lots of things that staff are doing to try and communicate with people, even though they're in PPE gear. And this is, I'm moving myself around so you can see this. So the impact on maternity care in Europe. And this is an interesting one because basically it does say that in the UK there is evidence, again, staff from BAME backgrounds are disproportionately affected, and there have been 3 working midwives from COVID-19 who've died in the UK and 2 in Italy. But what it says really interestingly is that actually other countries, such as France, Spain, and the US, have not experienced similar levels of death among healthcare workers. So this again raises a question: is it just about PPE, or are there other issues going on here? And are there ways of protecting staff so that they can still provide the kinds of service and the kinds of care they want to? And what do women say? Well, there have been lots of studies. This is just one particular one. Hannah Darland's done a one with thousands of responses that she will probably be talking about at some point, and I'm sure that'll be interesting. So this particular study was looking, I think this is a US one, and there is a lot of psychological morbidity. So 18.6% reported depression, 19.6% of women inadequate support for childbirth, 20% worried or didn't feel safe giving birth. But again, what this concludes is that it's really important that we pay attention to the psychological well-being of women. And it also, also implies that quite high proportions of women don't experience these things, quite surprisingly. But still, it makes the point that some do and quite high proportions do. And it's really important we pay attention to that. So what WHO has said in terms of what we should be doing about this is during COVID. So as you can see, all women have the right to all of these things: antenatal care, newborn care, postnatal care, mental health care. All women have the right to a safe and positive childbirth experience, whether they're COVID-19 positive or not. And all women should be offered to breastfeed, even those with COVID-19, and have their baby skin to skin. This should all be done. There's no reason why not, says WHO. And there are other guidelines that support these approaches. This is the Royal College of Midwives, Royal College of Obstetricians and Gynecologists guidelines that say similar things. But of course, we know this is what should be happening, but we also know that what has been happening is not that. So, at the very beginning, the American CDC recommended separating newborns. I hope that isn't still going on around the world. Separating newborns from mothers, that is not backed up by the evidence. Pregnant women being forced to give birth without support, I've already alluded to, not backed up by the evidence. And we also know that obstetric violence, the domestic violence is going up for women. And then there's this notion of violence or disrespect or mistreatment during birth. There are some claims that's been going up during the COVID pandemic, usually through interventions that women are told they have to have, even though they don't necessarily need them or want them. And I've already told you about this study about how many women are allowed to have a partner present. And what's interesting about this is how much it varies. So again, in the UK, we're doing a study on this now, and there are many others that have reported. This is not our study, but a campaigning group that put this information together, which actually resulted in a question in the House of Commons, that there's such variation between how many? So only 23% of in the NHS hospitals allowed their women's partner to be present throughout labour, and then you can see that there are larger numbers that allow them women to have partners during scans, but still only just about 50% or so. Most allowed, and again, the term "allowed" is problematic here because it shouldn't be a question of allowed. It really should be a right for women to have this. And the questions really are, who should decide what safe is? Are these the people that decide what safe is, or do women and families decide what safe is, or do we do it in partnership together? So there again, this was published in September. Basically, there is a real feeling in the UK, specifically in many other countries, that the COVID rules have gone too far. And positive is possible in COVID times. So there's this great site called the Positive Birth Story Project. You can go online and see. And these are stories from women who've had positive births during COVID. Some of these, I think most of these are cesareans or inductions, but there are also stories of positive physiological normal birth. These are all physiological normal births, in water, out of water. I think one of them is a home birth that have been happening during COVID-19. So these things are possible. We just have to find out who's doing them and how they're doing them and learn from what they're doing. And there's also been some other unexpected positives. As I've said, this discussion about maybe more mothers are breastfeeding because they're getting more space and time, at least if they have the luxury of that. And there has been some debate about whether actually prematurity is going down. This is somewhat controversial, and there now is some discussion that it may not be true. But in Ireland and in Denmark, the neonatologists noticed that far fewer babies were turning up in the neonatal units. And some of the discussions around that were, well, maybe because women aren't going to work in early pregnancy, they're not picking up viral infections, or because they're at home, they're getting more support from their partners, they're not working so hard, they're not so stressed. Maybe that's caused a reduction. But as I say, it isn't yet particularly clear whether it's a real phenomenon or just a glitch. But anyway, interesting. And again, these are UK examples, but there are examples from all around the world of things that have been put together, particularly online, to really support mums, going back to that sense of the loneliness, but supporting mothers both antenatally and in preparation for labour and birth and postnatally through the internet where they have access, or through their mobile phones. And in India, I came across this, which I thought was a really interesting piece. Basically, I don't know if I've got a colouring thing on this. No, I haven't. Let me go back to that one again. A highlighter. So, this is following WHO guidelines. Women should be accompanied. They should be supported to breastfeed, have skin-to-skin contact. Procedures such as cesarean should only be performed where they're medically necessary. So there are clearly moves in India, as many other countries, to try and maximise the potential for positive birth at this point. Positive physiological birth where, and positive birth with interventions if that's required or wanted. And there are new initiatives as well. So some of the ones I've shown you are existing ones, but these are new initiatives. And here's another online new initiative for women that, again, it's a UK thing, but I'm sure lots of people outside could access it if they want to. And there are sites that are sharing solutions, which again, people listening to this might be interested to go and find. So the Birthplace Lab here from Saras Vedam and her colleagues has got some excellent evidence-based information related to COVID-19 that people can pick up. And this site, All for Birth, has got some great stories and practical hints and tips. So this is about using water for labour and birth during COVID-19 for those places that have access. I know that's not necessarily available for many people listening here because you wouldn't have the resources to do that necessarily. But if you did, then here's a place to go. And there are many other stories in there that could be used in any setting that require very little resources or input to make them happen for women. And we also know that relationships work. So this is the evidence on continuity, that where women have companionship in labour, or where if you're in a country where you're able to provide continuity of midwifery care specifically throughout labour and antenatal, intrapartum, postnatal, we know it makes a difference. So 16% less likely to miscarriage, less likely to need regional analgesia, about 1 in 4 times less likely to experience preterm birth, and less likely to have an episiotomy. All of these things are less likely then to mean that midwives have to get close to women to do procedures, which means that midwives are less likely to be infected. So this kind of companionship reduces length of labour, reduces exposure of staff, reduces exposure of women, increases the possibility of straightforward birth, therefore reduces the exposure to interventions, all of which reduces the risk of infection for everybody. So it's really a good thing. So I want to just kind of finish here with a couple of examples of what happened in other kinds of pandemics. So this particular one is the Ebola example in Liberia. And I've got this one up because it says explicitly that what's important is building responsible leadership and social capital, strengthening bonds and trust in key actors. So it's basically saying, look, if another pandemic hits, the way we make sure that we're prepared is by building strong communities and strong responsible leadership in the community so that we have resilience at community level. And this has also come out through in this particular pandemic. So here's a paper here in the Lancet, which says the same thing, and a very heartfelt plea from doctors in Italy, which this came out quite early in the pandemic in March, as you can see, when in Italy they were completely overwhelmed in the hospitals, and they were saying, treat more people at home. This is a message for us as well, that actually when you get a big pandemic or a tsunami or an earthquake, whatever, hospitals get overwhelmed, and you have to build community resilience to be able to deal with those phenomena when they happen, as well as making sure that the hospitals are as resilient as possible. We have to build out inequity. We cannot carry on with this huge disparity in outcomes for marginalised groups, and particularly Black and Asian minority groups. It can't go on. This is a guide that was set up by a group produced by a group called Birthright, which is a human rights organisation. And it's a flowchart to help organisations decide how they can keep their services running or how they can change them if they need to, in this case, pandemic, or it could be anything. It's quite useful. And if anybody's interested, they can contact Birthrights. It's a tool that could be very helpful for future pandemic management. So going back to this both and issue, both for service users, neonates, parents, families, staff, being personal and safe, both those things really matter and can be done even in a pandemic setting, in a pandemic situation. So this is a famous quote often attributed to Einstein, not necessarily his, but still. So doing the same thing over and over again, but expecting different results is a definition of insanity. Perhaps, this is my take, the definition of sanity is doing different things until you get different results. And maybe those different things are building back better around positive relationships, and building strong infrastructures so that we can actually go forward with positive, in our case, labour and birth into the future, both for the remaining months, hopefully only months of the pandemic, and for what happens afterwards. So building future services for joy and human flourishing, as well as for safety in the intrapartum period, but also the ante and the postpartum period, and more generally. So the both and message that I want to leave you with. Thank you very much.